Hello, everybody, and welcome back to Emergency Medicine Quest, starting our respiratory medicine series. In this lecture, we are going to talk about COPD, so make sure to like, share, and subscribe to the channel for more such content. COPD is a very common ED presentation, and in itself, it poses a lot of financial burden to the healthcare system. It is also a leading cause of death across the world. So there is basically an organization, if you will, called GOLD that basically manages and creates guidelines for COPD. And they have a mouthful definition of how they define COPD. But we will start off by understanding that COPD is a disease that is caused by airflow limitation, and what creates this airflow limitation is significant exposure to noxious particles or gases. COPD does have a genetic element as well, but the most common environmental element to COPD is exposure to cigarette smoking. So let's start the topic by talking first about the anatomy and the pathophysiology. So anatomy wise, we know that we have what is known as a tracheobronchial tree. Now this is composed of our bronchioles and our alveolar ducts. And each functioning unit of the lung is known as a pulmonary acinus. The way our bronchioles remain patent is by the cartilaginous structure they have, and the way our smaller bronchioles stay patent is with the recoil of the lung parenchyma. Now let's say this person gets exposed to smoke from the cigarette or dust particles. This exposure is quite inflammatory to the lungs, and what rushes to the scene is our lymphocytes, our neutrophils, and our macrophages. But over time, if this person keeps having this repeated exposure from cigarette smoking, from dust particles, then the person is going to have a chronic inflammatory response, and generally any chronic inflammatory response leads to remodeling and destruction of whatever normal tissue that is there. Now, if the inflammation occurs in the bronchioles or in the airway, then what it does is it causes increased mucus production. And if there is inflammation in the lung parenchyma, then it is going to destroy the tissue matrix. Remember, I told you that neutrophil is one of those cells that rush onto the scene of inflammation. Now, although neutrophil is designed to help our body, but what it also does is every time there's an inflammation, it releases something known as elastase. Elastase is infamous for basically destroying the matrix of the lung parenchyma. In a normal person, generally this process is inhibited by our alpha 1 antitrypsin. There are people who are deficient in alpha 1 antitrypsin, and that is why these people are very notorious to developing COPD, as well as people who are chronically exposed to these noxious stimuli. Now, traditionally, what has been taught is that COPD patients can be divided into two: emphysema and chronic bronchitis, whereby in emphysema what we see is basically destruction of the lung parenchyma, and what we see in chronic bronchitis is the increased mucus secretion, and it is basically defined as presence of cough and mucus production for at least 3 months over 2 years. And we know that emphysema are known as pink puffers, and chronic bronchitis people are known as blue bloaters. But recently it's come to light that this categorization is no longer important. People who present with COPD often present with both these pathologies present and overlapping with each other. COPD is a very progressive disease, and as the time passes, the more of parenchyma is destroyed, the more of the bronchioles are destroyed, we notice that patients start developing chronic hypoxia. So no matter how much oxygen you provide, their saturation is always somehow going to be at 90% and 92%, and they will be fine at that. We also notice that after a period of time, these patients start developing pulmonary hypertension. And this is because of the changes that is noticed in the pulmonary vasculature and the surrounding structures. And because there is no problem with the person breathing in air. So the person breathes in air, but that air is unable to get out of the lungs. So we see that there is what? Air trapping. Hence why these people are going to have increased functional residual capacity, increased residual volume, and overall their lung capacities increase. And as the lung capacity increases, because this increased air has to now be accommodated inside the lung, we see that diaphragm begins to flatten. And sometimes in some patients, the rib cage also increases in the anteroposterior diameter. The diagnosis of COPD must be considered in people who present with progressive dyspnea, with sputum production, chronic cough, recurrent respiratory infections. But the sure shot diagnosis of COPD requires a proof from spirometry, in which it must demonstrate that the FEV1 to FVC ratio must be less than 0.7. There is a gold classification for the severity of COPD. If they have FEV1 more than 80%, it is mild COPD. From 50 to less than 80 is moderate COPD. From 30 to less than 50 is severe, and less than 30 is very, very severe COPD. Often a COPD patient might present with a COPD exacerbation, which is basically an acute worsening of their respiratory system from their baseline. It can be triggered by respiratory infection or any change in the environment, particulate matter or pollutants, or sometimes even temperature. Most common bacterial causes are the same as those that cause otitis media, so Haemophilus influenza, strep pneumonia, and Moraxella catarrhalis. And the most common virus that causes COPD exacerbation is rhinovirus. Normally, if a patient presents with COPD exacerbation but you are not able to isolate an infectious cause or a clear exposure, then these patients must be screened for PE. A small subset of COPD patient can also present with respiratory failure. These patients will present with small, frequent breaths through pursed lips, and this sort of a breathing pattern basically decreases the exhalation time and increases the dead space ventilation. So what happens is, imagine somebody, they inhale and then they exhale. In COPD patients, they inhale, and when they have not completed their exhalation process, they inhale again. Then as they are about to exhale, they inhale again. So you can see how there is an increased air trapping and over distension in the alveoli. Because of this, there will be an increased work of breathing, increased dead space ventilation, and respiratory muscle fatigue. All this air that is accumulating will cause hypercapnia, and it may culminate in a respiratory failure. So no respiratory failure, they will be tachypnic. Their respiratory rate will be between 20 to 30 beats per minute. They will have a normal work of breathing. They will be in their baseline mental status. There might be some mild hypoxemia, but if you put nasal cannula, then it responds, and there will be, most importantly, no hypercapnia. When they come with acute respiratory failure, in that case, their respiratory rate is going to be more than 30 breaths per minute. They will have increased accessory muscle use. They will still be in their baseline mental status, and if you measure their PaCO2, it's going to be about 50 to 60. So we know that's already elevated because the normal is about 40, 45. And if you measure their pH, it's going to be less than 7.25. But if the same patient comes with a PaCO2 of more than 60 and their pH less than 7.25 with some change in their mental status, then you must consider that this patient is in severe respiratory failure. When patients present with acute COPD exacerbation, it is important to bear in mind what would be our differentials so we don't get sidetracked. So things like pneumonia, pneumothorax, pulmonary embolism, pleural effusion, pulmonary edema, they must be considered. As we mentioned before, the diagnosis of COPD requires spirometry proof, which can mostly be done in the outpatient setting or in the inpatient setting. In the ED, we can maintain some level of suspicion if the patient has not been diagnosed with COPD but coming with COPD like symptoms and with risk factors suggesting it. A chest X-ray should always be obtained in these patients because not only are we evaluating for COPD, we are also ruling out any underlying causes like pneumonia, pneumothorax, P, atelectasis, malignancy, because they are still in our differential diagnosis. What are we expecting to see in a chest X-ray in a COPD patient? Do you see how the diaphragm here is well curved? In a COPD patient, as we mentioned before, this diaphragm will not be this way, especially if it's a long-standing COPD patient. We expect to see flattening because of all the air that is accumulating inside and getting trapped. If we take a lateral X-ray, then we can also see increased antero-posterior diameter. Some of the other diagnostic testing that we can do is VBG. In an initial VBG, we are looking for is this patient in any respiratory failure or not. So we're looking for PaCO2 and we're looking at the pH. A normal PaCO2 on a VBG basically excludes any hypercapnic respiratory failure. But if you see that there is extreme hypercapnia or there is extreme hypoxia, then we need to get an ABG to confirm that. An ECG should be performed in all cases presenting with acute dyspnea because there can be some underlying tachyarrhythmias like atrial fibrillation, flutter, multifocal atrial tachycardia, which is most associated with COPD, or ventricular arrhythmias that occur in patients who come with COPD exacerbation. The patients with COPD are also at an increased risk of ventricular tachycardia when compared to normal general population. Labs wise, a lot of doctors rely on CRP to find out if there is an underlying infection, but what literature as of now recommends is WBC counts with left shift and the presence of procalcitonin is a good screening tool to determine whether this patient is going to need antibiotics or not. Let's first talk about management that is specific to COPD, so the general guidelines of management. One of the cornerstone of COPD management is use of short-acting beta agonists with or without short-acting anticholinergics. Short-acting beta agonists basically work by stimulating our beta 2 adrenergic receptors and that increases cyclic AMP, and this mechanism produces a functional antagonism to bronchoconstriction. Short-acting anticholinergics basically prevent the bronchoconstrictive effects of acetylcholine on M2 receptors. What is recommended to do in the ED is to go for nebulization, particularly air nebulization as opposed to oxygen nebulization if present. Patients must be given short-acting beta agonists hourly for 1 to 3 hours and then every 2 to 4 hours based on how the person is responding. but continuous nebulization in the ED is not recommended. The second principle of management is glucocorticosteroids, because these are potent anti-inflammatory mediators and they decrease recovery time, improve oxygenation, improve lung function, and decrease hospital length of stay in COPD patients. Now, there's often a question of whether you should give oral or whether you should give IV, but what the recommendation says is both are equally bioavailable. So, as much as you can, if the patient can accept oral medications, he or she may be given oral steroids. So, what is the dosing that is recommended? The dosing is 50 milligrams of prednisolone for at least 5 days. Principle of management is antibiotics, but this in itself is quite controversial. Gold recommends that patients must be given antibiotics if there is an increased sputum production as well as dyspnea, particularly patients with chronic severe airflow limitations like those who have known bronchiectasis or they're requiring mechanical ventilation, then they must be covered for pseudomonas. Rosens recommends that either you can give a 5-day course of macrolides or a 7-day course of augmentin or tetracycline as initial antibiotic therapy, and you must give them follow up. And in the follow up, what must be the marker of improving infection is if their sputum production has decreased. But any patient requiring non-invasive ventilation must be on antibiotics, or if they've been endotracheally intubated, they must be on antibiotics because there's a clear literature proof that demonstrates decreased mortality if we start them on antibiotics. Now, as we know that COPD is a disease that is caused by smoking, so patients must be counseled on smoking cessation. Their inhaler technique must be assessed. They should be up to date on their influenza and pneumococcal vaccines. Finally, on to respiratory support. So starting with oxygenation, we know that hypoxemia is a very common findings with those who are coming with either acute COPD exacerbation or severe COPD. What precipitates hypoxemia is actually multifactorial. So there is hyperinflation, there is bronchospasm, there is mucus plugging, there is alveolar infiltration. Both hypoxemia and hyperoxemia in patients with COPD should be avoided. So the way that oxygen must be given is that our PaO2 must be more than 60 and our oxygen saturation must be in the ranges of 88 to 92%. If the patient gets exposed to high concentrations of inspired oxygen for a prolonged period of time, then that is going to cause hypercapnia. You must have noticed when visiting your ED that a lot of patients with acute COPD often receive non-invasive ventilation. Now, non-invasive ventilation has known to decrease mortality, intubation rates, and hospital length of stay. So the question arises, when do we start a patient on non-invasive ventilation and when is it contraindicated? So it is indicated if the person is coming with severe muscle dyspnea and you're starting to notice that their muscles are fatiguing and they have accessory muscle use, or on their VBG you've noticed that their pH is less than 7.35 and their PCO2 is more than 45, and they're coming with persistent hypoxemia despite how much ever oxygen you give, the saturation's just not picking up. The contraindications for non-invasive ventilation is if the patient is actively vomiting, so most certainly you cannot put on the mask, or the patient is in a respiratory arrest, or there is some facial trauma. The settings that are recommended when a patient is started on non-invasive ventilation. So for inspiratory positive airway pressure, the patient should be initially started on 12 to 15 centimeter H2O, and the expiratory positive airway pressure should be 5 centimeter H2O. The face mask should be tightened in a way that there should be no air leak, and remember, our goal oxygen saturation is 88 to 92%. If we start the patient on these settings and we note that the patient is not picking up, the saturation is not picking up, so what we can do is we can increase our IPAP. We can increase it by 2 or 3 centimeter H2O every 2 to 3 minutes, but the maximum IPAP that we should go is 25 centimeter H2O. What are our markers of success? Our markers of success is if the pH starts to pick up, so it improves, and our respiratory rate decreases. Now let's say we did everything that we could, we have reached the maximum IPAP, but still the patient is looking very sick, very fatigued, very acidotic. This is the time when we must think about intubating this patient. What are our indications and contraindications to invasive ventilation? Indication is, first of all, if the patient has failed NIV or is not able to tolerate an NIV. If the mental status keeps decreasing, if the patient experiences cardiac arrest, if there is hemodynamic instability despite giving fluids. But what are our contraindications to ventilation? So first, if the patient can tolerate NIV, the patient must be given NIV. Let's not jump to intubating every COPD patient. And the second is just the patient's wish. If the patient has an advance directive that says do not resuscitate or do not intubate, or the patient is just refusing to be intubated, then that must be respected. This brings us to the end of COPD lecture.